and also at NUS, National University of Singapore, and also Senior Research Fellow at the Center for Research in Health Systems Performance. And she will be talking about a project that is very dear to our, well, that is very one of our priorities over the coming years. Laurie has an MSc in Health Research Methodology from McMaster University, PhD in Health Policy from the University of North Carolina, and has worked across the US, Canada, and Singapore. Has a wealth of experience. She's a seasoned mixed methods researcher, and she has been with our department for the last year. And we were really happy to be able to recruit her into the department. And well, she will tell you very, very interesting things about this initiative called DIPEx, and it will be only the first of very many similar sharing exercises that we will do in relation to DIPEx over the coming months. Over to you.
Thank you very much. Yes, I'm very excited to be speaking about this, both to the people in the room and the people online. So we do have some embedded videos a bit later in the talk, and we think we have it working, but we will check to make sure that it's working well. Oh, can't hear. So, oh, now it's okay. Yeah. Good. So, so I'm going to talk about a couple of things. Why do we care about patient experiences? Why do we do qualitative research on patient experiences? And then I'm going to get into the meat of the talk, which is about DIPEx, the database of individual patients' experiences, and talk about it as the origin, and talk about it in the international perspective, and then talk about why we're bringing it to Singapore and how we're bringing it to Singapore. And then, because this has some overlaps with patient and public involvement in research, or patient engagement and research, I'm going to take the opportunity to insert a little bit of information about what we're trying to do in terms of patient and public involvement research in the Department of Family Medicine. But let me be clear, DIPEx is not the same thing as PPI, or patient and public involvement. There's a lot of similarities, there's a lot of the same philosophies, but it is not the same thing. DIPEx inherently does not, well, I'll stop there and you'll see. Okay, so I know a lot of people in the room know this, but let's just make sure that everyone's on the same page. So why do we care about patients' experiences? Well, first of all, we're interested in patient-centered care. If we want to do patient-centered care, we need to understand the patient's perspective. It's impossible to do patient-centered care without understanding patient's perspective. Also, the patient experience and improving the patient experience is one of the 4 elements of the quadruple aim. In addition, the quadruple...
Yeah, but I can see the slides on my end. Oh, great. That's true.
Leithun has put in the chat she can't see the slides. Can anyone else online not see the slides? Could you put it in the chat as well?
We can see the room, but we can't see the slides.
The room, but not the slides.
Yep.
Tanya said she can
see the slides.
Oh, okay, yep. I have 3 screens. Sorry, my bad.
Okay, okay, great. So, and the quadruple aim, let me go back to the quadruple aim. So thinking about the patient experience is one element of the quadruple aim, but also there is evidence, research evidence, that if we improve the patient experience, it can actually improve the other 3 elements of the quadruple aim. So the patient experience, improving the patient experience is a very important component of the quadruple aim. And then we care about local patient experiences. We can't just always import research evidence from outside of the context that we're in, because how the healthcare system is structured, different cultural understandings of illness and disease, different cultural perspectives on how you present to systems, how people interact with each other, all of that is context specific. And then we also have any specific cultural issues at play that interact differently with the local context as well. So we need to worry about patient experiences writ large and from a local perspective. And then why do we care? Why do we use qualitative research to do patients' experiences? Well, first of all, qualitative research is about discovery. So it allows us to understand what we don't know. And while every single person in the room and online has been a patient at least once in their life when they were born, but probably more than once in their life. We still, though, because we are working and we tend to operate in a fairly privileged element of society, we have one perspective on the patient experience. Obviously, we need to understand what the entirety of the patient experience is. And so we need to go directly to patients and try to figure out what we don't already know. Well, that's what qualitative research does. It allows us to discover new things that we don't already know ahead of time. And then the most rigorous and direct way to deeply understand patients' experiences is qualitative research. If we want to generalize to populations, that's another thing entirely, that's quantitative research. But if we want to understand things in a very rigorous and deep way, as efficiently as possible, we go to qualitative research. Okay, so now I'm going to make sure that everyone's on the same page about agreeing that we should care about patients' experiences and we should use qualitative research to it. Let me talk about what DIPEx is. So this stands for the Database of Individual Patients' Experiences. It was started in the late 1990s, and then by the early 2000s, they were publishing the first research to come out of DIPEx. There were two clinicians who were friends at the University of Oxford, and both of them happened to have illnesses that they were interested in understanding what the effects might be on their life. So Anne McPherson, who's a GP, she was diagnosed with breast cancer, and Andrew Herxmeyer, who's a clinical pharmacologist, was needed to have a total knee replacement. Both of them went to the web to see what they could learn, and they saw information about what it was like to have these health conditions, but not that in a way that satisfied them. They didn't just want the flashy celebrity talking about how they beat breast cancer, or they didn't just want one person's blog. They wanted something that was the equivalent in understanding, in terms of rigor, of the Cochrane collaboration. And part of that is because Andrew Herxmeyer was also part of their Cochrane collaboration. So the same idea about summing together information informed the creation of DIPEx. So this eventually at Oxford became what is called healthtalk.org. It comes from the Medical Sociology and Health Experiences Research Group in the primary care department at the University of Oxford. So it very much has roots in family medicine. It is now evolving into what they're calling health experience insights. Right now, you can get the information on both healthtalk.org and HEXI, but it will eventually more transition to HEXI. Other countries really liked what Oxford was doing, and other groups wanted to join what they were doing, and this became DIPEx International. As of this date, DIPEx International consists of 14 countries, mainly from the West, but you can see down at the bottom with the red arrows, two countries from this region that are part of DIPEx International are Japan and Korea. Singapore will be the 15th country and third Asian country joining this collaborative. So there are two parts essentially to the DIPEx methodology. The first, all of it is built on a bed of rigorous qualitative research. And those of you who are familiar with qualitative research will recognize many of these elements. I've highlighted in yellow some extra bits that are demanded in the DIPEx methodology. So you do one-on-one interviews with people with a particular health condition. So let's pick breast cancer. So if we're doing a module on breast cancer for DIPEx, we find women with breast cancer. We start off with a minimum sample size of 30, and we go to saturation. So 30 to 50 is the recommendation for DIPEx. It intentionally starts at a fairly high number as its minimum sample size, because one of the objectives is to get as much variation in the patient voice as possible. So not surprisingly, the sampling strategy is maximum variation, purposeful sampling. Within that, though, there's very much an emphasis on making sure you represent the breadth in the country that you are studying. So smaller countries like Singapore without ethnic enclaves, we have a luxury here that we can actually sample across the whole country. Other countries like Canada can't actually sample across the whole country, but they do geographic areas, and they try to pay attention to different ethnicities around the country. The UK, they go all around the country. The researchers physically travel to be able to do the interviews. They also record the interviews, not just audio, but also video, obviously with permission of the study participants. However, most people do give permission to be video recorded. And the idea behind video recording is to be able to put it up on the website to share with people, and we'll show you what that looks like. Standard analysis of reflexive thematic analysis. And then because of the website involvement, the transcripts are returned to the study participants, not from member checking, but to allow people to be able to identify what should not be shared publicly, widely around the world on a website. And they have the option to be able to say, this can be used for research, this part of my transcript can be used for the research projects that come out of DIPEx, but it can't actually be used for the public shared website. Okay, so the last thing that is slightly different than what you might have seen in qualitative research before is an interviewing approach called narrative interviewing. And the narrative interviewing approach is very much letting the study participant, the patient in this case, be in charge of their own narrative. So again, to go back to if we're doing a module on breast cancer, we would say to the woman with breast cancer or the man with breast cancer, if we're including men in that study, I'd like you to tell me how you got to where you are today in your breast cancer journey. And why don't you start with talking about your initial signs and symptoms, and then what happened along the way. Now, with that sort of invitation, somebody could talk for half an hour, 45 minutes about their breast cancer journey. And the interviewer is there to do a few prompts to reinforce some things. And then there's an interview guide, a second half of an interview guide that is there to be able to pull from, to be able to cover some areas that perhaps people had not spent as much time on in the interview, or we want to make sure that we ask of everybody, or to give the interviewers some ideas for elaboration in prompts during the narrative interview. So we want to cover the entirety of the narrative, wherever the person is. So again, if it's breast cancer and the person is considered to be completely recovered from their breast cancer experience and back into regular life, you want to work through all of the sequences about treatment. How did you decide what treatments to have? What treatments did you decide not to have? What was it like getting the diagnosis? What was the impact on your life, both short-term and long-term impacts? And what is life like now? Now, if you're interviewing somebody earlier in the disease process, then you obviously won't be talking to them about what it's like to not be ill, although they might want to talk about what they imagine life is like, not being ill. So we're really interested in capturing the entirety of the patient journey. Oh, sorry, there's a typo on the top of this slide. This is supposed to say part 2. So the second major element of the DIPEx methodology is that in addition to all the research products that you normally do, like peer-reviewed publications and conference presentations, is you create a website that is publicly available where you share the results of the study in a publicly friendly way. So for each health condition of interest or module, so the breast cancer module that I was walking you through, you want to use all of the themes that you created from the patient journey. You put those up on the website, and then you select clips to illustrate those themes, and you do something called a detailed topic summary. So say the topic was shocked at getting the diagnosis. Then you do a little summary about what that looks like in the data. You pick various audio and video and written clips that go along with that. So then anyone visiting that website can see the variation in being shocked at getting your diagnosis of breast cancer. The other element to go along with the website is every DIPEx member country has to have an evaluation strategy for the website. So at the very least, they need to be asking people to give input on whether they think that the website has been helpful, and then track that over time. So these are some screenshots from healthtalk.org, so the UK. So this is from their module about diabetes. This is what it looks like within a particular theme. So you can see running down the right-hand side are a bunch of themes, and you can click on each of those themes, and then you get to see what's on the left-hand side of this part of the slide. So you get to see the little bit of summary, and then you get to see video clips. You can click on them and listen to what people say, and then there'll be audio clips and transcript clips. And intentionally, you're trying to have different types of faces, right? So you're making sure that people can see someone who looks like them. Then there's another part to go with every module, and that is a profiles of who is part of the sample. And again, you could go to this part of the website and say, I'm a young woman with diabetes, type 2 diabetes. I want to find another young woman with type 2 diabetes. Or I'm of East Indian descent, and so I want to find somebody else of East Indian descent. So I can look at the face of me, try to find somebody. Or I've had it for 20 years, I want to find somebody else who's had it. So both the DIPEx International movement and in DIPEx Singapore, the emphasis is on having as much diversity as possible. So you want to have diversity in terms of demographics, in terms of gender, and in terms of the clinical condition. So you can see down here that you've got how long people have had the illness for. And then this is an example from the German, Dutch.
Canada.
No, I don't think it's Canada.
This is Canada.
Okay. Anyways, we're pulling examples from different countries. So, and then this one. So this, I can show you dynamically what it looks like. So this is from the UK website. And again, we want diversity across the journey. So you can see slightly bigger than what I had on the previous slide. You can scroll down to see what colorectal cancer looks like. And you can click on any of these and get to different parts of the website. Yeah, so it's a little slower. Sorry, I have to remember not to move my mouse. So you can see there's different clips. And then it's also, as I've already said, it's multimedia. It's also, depending on the country, can be multilingual. So Singapore, our plan in Singapore is that as much as we can, we want to represent all the 4 languages in Singapore. Of course, that depends on our funding ability, because it's costs more money to be able to integrate multiple languages. And because we still have to do academic products under the work, we have to translate everything back to English or one new language, which if I'm involved is going to have to be in English because I don't speak Mandarin or Tamil or Malay. Of course, that is fairly resource intensive, but the idea is we want to be able to have different languages on the website. And this is going to be my first attempt at making sure that even people online can hear this. So this is from the Japanese website. So just to give you an example.
検査をしたのが、がんセンターに最初行ったのが。
So I'll stop there. Can people online hear that?
Yes.
Great.
Yes.
Yes, yes.
10月ぐらいだったと思いますけれども、12月にその政権の結果が出まして、そこで、割合その。
But I will also say that we had to go for training in Oxford to be able to apply to be a member of DIPEx, and we spent a whole day learning how to do videos well and what not to do, and how to work with people in their homes and find the right sort of location. So at the Airbnb where we were staying, actually we walked around and we had to say, okay, what if we were taken to this room by our interviewee? What would you do about the fact the light's coming in this way? What would you do about that flowered couch, etc.? So they are even down to the level of making sure that the videos are well constructed. They've added now post-COVID, if you're doing interviews on Zoom, how do you coach people on Zoom to even get their head in the right place and on the camera on the Zoom? So we're all learning some new techniques that as qualitative researchers we didn't have before. And then this one is the Canadian website. And so this is an example of an audio clip. So this person is talking about what it was like to talk to her children about cancer.
Children are going to be the hardest thing to put into this equation. I think if he wasn't around, it would be so much easier because your brain goes to what's going to happen? Am I going to see him go to grade 12? Am I going to be able to be there for him? And it's really, really difficult. And then how much information do you tell him? And one thing that I really realize is that.
So I want to point out, obviously people are upset in some of these clips, right? But they have given full permission for this to be shared. People are very passionate about wanting to share their data. And in addition to the regular IRB process that we're all used to doing research, then there's extra steps on top of it to make sure that people understand about it being on the website, that people could use the clicks for nefarious means. If you use your real name rather than a pseudonym, that people might more easily be able to identify you. And all of this has already been worked out by the Oxford group and the countries that come before us. But the study participants, the actual patients themselves, have all given permission for this to be shared with the world. Okay, so what is it going to look like in Singapore? So this is a joint initiative of CRiHSP and of the Department of Family Medicine. The requirement to apply to be a member of DIPEx is you have to have a co-leadership model with an expert qualitative researcher and an expert clinician that has connections with lots of different types of illnesses. They recommend that that's usually an academic general practitioner that has that kind of relationship. Then you need to, for each health condition, so on the right of this screen, you need, in addition to the research team, you need to create an advisory panel of experts, including patients and caregivers, or caregivers if it's relevant, health professionals and researchers with an interest in the topic that are not part of the research team. And we use this advisory board for the module at various points in time, like a traditional advisory board for research to give you ideas about how to recruit, for instance, and how to analyze the data. But you definitely are required to use this expert advisory board for each module before you launch the website. There, you ask them to review the summaries that you created for the websites, to review the choice of the lists. And so you get a lot of input there. So here's where DIPEx starts to overlap with patient and public involvement in research by having patients and caregivers as members of this advisory board. And here in Singapore, we've decided to also have an overall advisory board, and we're really pleased that we have support from the Patient Advocacy and Support Office, or PASO at NUHS, and the Alliance of Patients Organizations Singapore. And they're going to be suggesting a board member from their board to join us on our advisory board. We also will be recruiting 2 patients, members of the public, to be a member of our overall advisory board. And we're looking for people that already have experience with giving input into some element of the healthcare system. So things like SPAN, the Same Health Patient Advisory Network, for the clinical side. People who've already worked with SPAN would be nice people to have on our overall advisory board. We also want to get some local policymakers on the overall advisory board and 1 representative from national. And then we also need to worry about our website. So Mariel here in the room is going to be our expert on the website and how do we make sure that we're managing all of that material, and we'll be working with contractors around the website construction. So what topics do we know we're going to be studying? We already have funding to study colorectal cancer and to study recurrent infections associated with antibiotic use. We have applied for funding to study Singapore's top 4 cancers, so an expansion of the colorectal cancer work that we're already planning: breast cancer, lung cancer, and prostate cancer. So it happens to be a nice mix of cancers that affect both sexes and cancers that affect one sex over the other. We're poised to be applying for funding for diabetes. We're just waiting for the funding call to come out, and we have already written up a proposal for studying menopause, and we're looking for the right funding source to apply for that. But if there's any millionaire relatives of yours that you think might want to fund us to study another topic, we're happy to discuss it. So I'm sure you can see that there's lots and lots of uses for DIPEx, particularly the website. but let me make sure that everyone understands how it can be used. So as soon as the ETH module is launched publicly to the world, it's immediately available for patients and caregivers who are looking to understand their illness. And when other countries have asked people what they thought of the website when they visited, which is it's about 8 million people a year visit the DIPEx, at least one of the DIPEx country websites. Over 80% of people report that they found information on the websites that they couldn't find anywhere else. And most of the people visiting these websites are patients or caregivers. So it's clearly providing a very valuable resource for patients and caregivers. But we know that clinicians visit, policymakers, managers also visit, other researchers also visit. So for clinicians, it's used in training clinicians, in education programs, also used to just help clinicians understand patient perspectives of various illnesses. It can support managers and policymakers in understanding how to assess how patient needs are met. And then the entire database is also available for secondary data analysis by other researchers. And there is some work amongst the DIPEx countries when they've studied the same conditions that they do some work together. They even did some work on long COVID and were commissioned by the World Health Organization to create a video about the experience of having long COVID with people from various countries around the world. And you can find that both on the WHO and the DIPEx International website. So that's all that I'm presenting about DIPEx Singapore. But like I said, I wanted to talk about patient and public involvement in the Department of Family Medicine. So we're also very interested in making sure that we are have patients as members of our research teams. So to that end, we are both creating what we're calling the Department of Family Medicine PPI panel of having patients and caregivers that we get together 4 times a year. And then we ask them to give us input on various components of our research projects. So we might bring a survey, for instance, that we're going to be launching soon, and we ask them to give us some input on the survey. Or we're looking to publish a paper and we want to get their input on how we shared about the health condition in the paper. And then we are working towards making sure that all of the research projects in the Department of Family Medicine in the future have patients as research partners. So we are building towards that slowly. It's obviously something that we need to learn how to do. And we need to figure out how to fit it into the existing research infrastructure. Both Chima and I have done work in other countries where we've had patients as research partners while we've been supported by the research infrastructure, and we're still learning how to do that here. So the grant that I put in earlier this week, for instance, I had a patient research partner as one of the co-investigators. And one of the columns that I had to fill out about a co-investigator was their age index. So I originally had written in not applicable, but this person happened to have been involved in 2 research projects already, and we were able to construct an age index for her. But we'll see what happens. That funding source is only in phase 1, letter of intent. When you get to phase 2 and you have to put together your CV, how do you put together a patient CV? You know, in Canada, we've evolved the research infrastructure to the point that we have a separate approach for patients as research partners. We don't expect them to have an academic CV. That probably is not the case in Singapore yet, because it's still a new idea. But we are forging ahead as best as we can with PPI. So we're hoping that in a couple of years, we really will have patient research partners on every research project. So with that, that's the end of my slides. I have my email address on the next slide, and I'm happy to take any questions or comments.
Thank you very much, Laurie. Any questions? I mean, I can see that the chat looks very lively. See, okay, there are already a few questions there from Lei Hun. Perhaps Lei Hun, if you would like to pose the question yourself.
Yes, thanks. I have a few questions, but please feel free to choose the ones and then the others ask as well. So I was just wondering, how do we support patients who may be emotionally affected after they participate in the videos and interviews? Do we have any provisions to provide that support? And secondly, are there ways that we can evaluate the impact of DIPEx? And lastly, how can we reach out to people who are not able to access the websites? Thank you.
Yeah. Okay, so let me take on, so I'll take them on in the order that you put them on the screen, like, and thanks for writing them in the chat. So how do we support people who are emotionally negatively impacted by the interviews in the same way we do for all qualitative research? Particularly if we expect that people will be emotionally affected, IRBs usually require that we have a process already in place. So we have a list of resources available for people that you can refer them to, ideally that they are free of charge. But also the standard approaches of, you tell people ahead of time, you don't have to answer every question. Anytime you want to take a break, we can take a break. Other DIPEx countries have told us that sometimes they go back to people's homes more than once because people want to have a break, at least a day between components of the interviews. It's the standard approach to doing any qualitative interviews, which is also to some extent the standard approach of being a human being talking to another human being. Obviously, if somebody starts crying, you say, "You want to take a break? Would you like some Kleenex? What would you like me to do? Would you like me to leave your home? I leave your home if I'm getting you too upset." So, so it's the standard approach to qualitative research, plus recognizing that that we are dealing with some people with with particularly upsetting illnesses, and that we need to be prepared ahead of time. In terms of evaluating the impact of DIPEx, so we are required as a member of DIPEx to have standard evaluation of our website on an ongoing basis. So things like making sure that the material stays relevant, stays up to date. If treatments change, then trying to find funding to be able to update the website. And also tracking the website metrics and comparing them against benchmarks. There are other ways that we can evaluate the website that some of the other countries have done, doing evaluation projects, but you do need funding to be able to do that. So we need to be seeking out additional funding. And then how do you reach marginalized, vulnerable people who may not have access to the websites? No easy answer. The same way that you would handle any other information on the web. I don't know if it happens here in Singapore, but I know in Canada that organizations that support the more marginalized individuals do things like they get them web access, they make sure that people know about public libraries and being able to use the computers of public libraries. They share the information at their organizations. They do things like support people in getting internet access. So I assume similar things happen here in Singapore. And I would take guidance from others about that. So another question online from Shirley, how about generalizing qualitative data findings from informing policy-making purposes? So a reminder that qualitative research is not designed to generalize to populations. However, if you are doing maximum variation purposeful sampling and you are intentionally trying to find as much variation out there in the universe that you are targeting as possible, then you can say that as best as we know, this represents the universe of variation in the patient experience. We can't necessarily say that because 10 people in our study had this experience that it's 10% of the population in Singapore, but we can say that this is part of the variation of the patient experience locally. That is very helpful information for policymakers to know what variation exists and how does that variation play out. So does it play out that men seem to say this more likely than women? Does it play out in terms of different ethnic groups, in terms of different ages? That's very helpful information. And then it can also be used to build a base to do quantitative work that allows you to be able to generalize to populations. But I find that policymakers are very, very interested in variation and knowing that it's can be documented in a rigorous way. Let me just see if there's any questions in the room before I turn back to the chat. Any questions in the room?
I maybe can ask.
Yeah.
how do you publicize, or how do countries or the DIPEx countries publicize this website to the patients? What kind of platforms do they generally use? Is it through the hospitals, advocacy groups?
I expect that it's in every way possible. One of the nice things about the future of DIPEx, because you have this expert advisory panel that includes health professionals that know the condition and patients and caregivers, and because you've already been recruiting as broadly as we possibly can, you already have an automatic list of people that you've shared the website with, who then have their own networks that they share the website with. And this is also part of the reason why we're really thrilled that we're working with the Alliance of Patients Organization Singapore. So that is all organizations that have something to do with patients. So we send them one announcement that the website is live about the breast cancer module, they can share it with all the organizations, for instance. We also will be working with communications here in the US to promote as well and use their strategies. And then the website gets picked up by search engines as well, and gets promoted enough. So back to the chat. So Joanne Minsky and then Curvis asks, do you have an initial study planned or is that pending funding? So the first two on the chart that I showed are already funded. So colorectal cancer and recurrent infections associated with antibiotic use we already have funding for them. Not as much as we would like to be able to. We're not sure we're going to get full saturation, but we're going to get started. Definitely, we're going to be able to do a sample size of 30 with that initial funding. We may be able to tweak out a bit more. The bottom part of this slide is the conditions where we have put in funding for on the vertically funding applications for, and we're waiting to hear we're going to get funding back. There was a second part to Joanne's question, I think. Are participants compensated for the interviews? So it depends on the country's approach and the researcher's approach. So in the UK, they are not compensated for their interviews. They are provided with some money for, they have to do babysitting, or if they have, if there is a deliberate reason that they need money, they are given money. Here in Singapore, we're planning to pay people honorarium. As far as I know, in the US and in Canadian countries, they pay people honorarium for their studies. It depends on the tradition in the country around qualitative research and what the IRBs allow and the funders allow. And if others want to access the data, what is the governance process? So whatever is put on the website is publicly available. That's part of the reason why it's only just snippets of the interviews. It's not the entire video, hour and a half long narrative interview with an individual that's put up on the web. It's only snippets. It's only snippets of transcripts if it's written components of the interview. It's only snippets of the audio version of the interview. It's an audio clip. So the governance process around the access to the rest of the data is the same that has been set up for access to any research data. So it's put on a data repository. You can put restrictions on the access to the data. We are planning on putting restrictions to the access to the data. Other restrictions that we're planning here in Singapore are you must be a researcher or a student. You must apply for access. You must have a research protocol already in place. You must agree to get IRB approval before we release the data to you. And you must agree to not try to match up what is on the web with what you receive as the anonymized transcripts. We are planning on sharing the written transcripts in our data repository. In the UK, they take a different approach. Because they started over 20 years ago when data repositories didn't exist, they created their own data repository. They asked all their study participants to sign a copyright form in addition to the regular IRB forms. And so then the department at Oxford owns the transcripts and the audio clips and the video clips. And they charge for access to that data. Other than that, it's standard data repository rules around who gets access to the data, what sort of permissions do you have to sign. I believe Oxford also restricts it, so it cannot be used for commercial reasons. So, any other questions? So, will we be conducting interviews in non-English languages? Yes. Okay. So, Because, so the funding we currently have in place, because it's not large amounts of money, we will only be collecting the data in English. But the funding proposals that we have put in or on the verge of putting in are for all 4 languages in Singapore, so non-English languages as well as English and translation plus. Now, obviously, if we get the funding, but our budget is cut, one of the first spots that would be easiest to cut would be some of the languages and the translation costs, because it obviously adds a lot to the price of the budget. Other questions? How much will be representative of each ethnic group in Singapore? And how do we take into consideration socioeconomic status? So because we are doing maximum variation purposeful sampling, we do want to take into account ethnicity and socioeconomic status. So I'm happy for people to give me more information. I've been working in Singapore for 3 years, a little more than 3 years, and what I've been using as my surrogate for socioeconomic status is housing status. So how many rooms in the HDB, if you're HDB, or are you private home, private condo, etc. I have seen other researchers use household income for socioeconomic status, but I'm told that that's probably not a very good variable to try to ask people to self-report, as not everybody knows the entirety of the household income, and the definition might not work very well. It is a figure the way I've used in North America doing socioeconomic status is asking about household income in categories, but I haven't tried that here in Singapore. And so far we've been able to, in the qualitative work I've done here in Singapore, we've been able to get good variation by socioeconomic status, ethnicity, education status, and age groups, even when we're only interviewing in English. Obviously, we're limiting our samples somewhat when we're doing older age categories, when we're asking to do interviews in English, because not everyone in the older age category is as comfortable in English as the younger groups. Are there any other questions other than Leiden's? Okay, let me ask in the room. Any other questions in the room?
I have a comment, and I think it's a practical question. I'm so happy to see this happening. I've been as well. I say DIPEx, you say DIPEx. I've been working with DIPEx for many years, and I actually tried to get this off the ground about 5 or 6 years ago, and I left it lots of years and then came back. When I saw this, I was delighted to see that this is happening, that we now have this as an initiative here. I know that DIPEx International has been something that's been happening for a long time. I did the training with Susie Glenn. I was all ready to go, and then I left Singapore and it sort of went on hold. So I'd love to talk to you more about this after this. Just some comments. The topics that you've chosen, I think, are really relevant, and it's so nice to see things like menopause. And I know I do a lot of work on AMR, and I know that one of the things that the national strategy here has wanted is testimonials from patients with MRSA, and this is fantastic because it really fits within the policy landscape. So just congratulations. I'm so happy to see you doing this. On a practical level, how long do you think it's going to take to get from sort of inception to going live? What's your sort of timeline?
To going live?
Yeah.
It's going to be at least a year, probably more like a year and a half. So we're waiting every day with bated breath for the IRB approval on the colorectal cancer, and are aiming to collect as much data as possible before the end of the year for colorectal cancer. So that's why I'm sort of saying maybe a year for colorectal cancer, by the end of 2025, because we've got a lot of staff that we're ready to go with for that module. And I really want to see us produce something quickly. So then we have something to demonstrate to future funders about what this actually looks like in Singapore. Shiva, do you want to add anything?
No, yeah. I mean, that's critical. I think that on the one hand, we are really interested in getting something out, but also we wanted to have the adequate quality. But I think it will be, I mean, the value, I mean, in some of the applications, we had to remind ourselves of that we sometimes take for granted things that people don't really know. So, for instance, the issue of how much experience can help shape and improve services to make them really responsive to people's needs. And I think people need to see it in working with from a local perspective, because they can see something in Japanese maybe, or from Canada, and think, okay, maybe these things works for them. But if they see local people talking about going to the polyclinic, about services they received in the cancer center, that will immediately resonate with them, and hopefully that can also give us some clout in terms of continuing the work.
About specific audience, because I think, you know, the patient, the caregiver audience is really important, not just for information, but also to start dialogues between families, to, you know, when you first be diagnosed. I think it's a great springboard. But one thing that I was thinking about, particularly for the Singapore landscape, is, you know, health service improvement and sort of quality improvement trigger videos, using them to basically get the patient perspective across within the service sector, I think is another very useful way of positioning this kind of output. So yeah, so many ways that this can be used for practice and quality improvement, not just from the patient perspective, but also for a health system perspective. So yeah, super excited to see how this evolves.
Yeah, and I don't know if you're familiar with Glenn Roberts and experience-based co-design in the UK.
I didn't know.
So they create trigger videos essentially to start the co-design process. And he and Sue Liebland have actually worked together to see if the healthtalk.org videos could be used to be the seeds for these trigger videos for experience-based co-design without having to collect original data. And they have been able to demonstrate that that's a successful way to do experience-based co-design. So if the health condition has already been studied and is in the database, it can be used for things like other research methodologies. There's still
one question: who can contribute? Non-users such as funded to collect similar data, can they contribute to DIPEx? I think. Well, you get.
Go ahead.
No. I think that we want to develop this collaboratively. So I think that rather than doing it independently, I think it would be best to do it in a coordinated way. And I think that we can see that the landscape is vast in terms of what can be achieved. So certainly this can be achieved by multiple teams working in a coordinated way. So we just wanted to get these things started so that we can set up the process to set the process in motion and develop the process so that people can plug themselves into it. So at this very early stage, I mean, that there isn't yet anything that people can necessarily immediately plug themselves into, but very soon we'll be very happy to discuss how we can empower non-NUS people to develop the modules and contribute to this.
Yeah, and we really want this to be a Singapore-wide thing, but to use the DIPEx name, we have to make sure that we're following the DIPEx methodology, and we have to, it has to be associated with the accredited group to be able to use the DIPEx name. The idea is that at the DIPEx website, which one thing I can say is we're going to be calling it Health Experience in Singapore, like some of the other countries, because we don't expect people to understand what DIPEx is. So while you are a DIPEx country, you may call it something else. So Health Experience in Singapore, it will be one website, and you can click to get to different types of health conditions. So we'll all go under the Health Experiences Singapore website, and then it will link to the DIPEx International website. So there's still some of Layton's questions. So we scroll up, and then if there's any other questions in the chat or in the room. So Layton's question number 5: do patients participate in DIPEx signed written consent like usual research? Yes, they sign usual consent like written. So they sign usual consent forms, but there's some additional information on those consent forms. It is then you have to give independent consent to have your videos or audios or written clips on the website. That whole process is explained, including obviously once the website goes live, we lose control over what people in the world do with it. And so that is explained in detail elements. We'll see how the IRB reacts to that here in Singapore. But given that there are 14 other countries that have gone ahead of us, we're optimistic we'll be able to sort it out. So they sign traditional consents with some extra information on top of it, and people can participate in the research in DIPEx without being willing to be featured on the website. So it's two independent things, but people have the option of participating in the website in various ways. So they can participate through video clips, through audio clips, or through transcript clips. And even the audio clips, what they do on the UK website is they have a picture of something that has movement in it. So there's a whole series that is videos taken in gardens with flowers or blowing in the wind. And then the audio clip is played over it. The UK has also experimented with hiring actors to read people's words and to be video clips for that. And they've had various levels of success with that. It also obviously adds to the cost of the price. But this is very much about protecting people, about making sure that we are representing people appropriately. So obviously we want to make sure that the people are comfortable with how their data are being used. And that might be it for the questions.
There's one more message. It just arrived. Perhaps that's maybe the last one.
Okay. So how can this research be used beyond researchers, but also patient organizations who are working on evidence-based advocacy in healthcare organizations? So anything that would be on the website, Aileen, would be anyone can use it. They can immediately go to the website like I just did and play clips from the website. It is available for anyone in the public to use in any way, shape, or form. If organizations would like to use our data in a different way, then we can have some discussions around that. We have so far, we've only set things up to be used in traditional academic ways to repackage the data. But that's only because a process already exists for that. It's not that we're not interested in keeping the data to ourselves and only to university settings, but we need to work out what does that process look like that is responsible for people. So a double-barreled answer. Anything on the website is up for grabs, and we will work with anyone who is interested in understanding how do we do this in a responsible way and protect people's privacies and protect people's data, but still make sure that it's available to improve patient experiences and improve the healthcare system. So thank you, everybody. We've had a lively question period, and we look forward to hearing from all of you and working with you on this topic.
Thank you, Laurie, for the presentation. And thank you, everybody, for joining us today. I think it's fantastic to see the level of excitement that the initiative has gathered. And I think rightly so. I mean, we knew it very well that it was, and also you, even before us, had seen the potential for this in Singapore. And we're really looking forward to working with all of you to make this happen. So thank you all for joining us today, and please join me again in thanking Laurie for her presentation. If you want to know more, if you have ideas, if you want to collaborate, to contribute, to give us money, please do be in touch. Thank you.